Hello, everybody. Welcome to Ladies Lunch and Learn. We'll give it just a few more minutes for people to join till we get to the top of the hour and get started. Hey, Lenika. Get the slide deck. Make sure that's working. Perfect. And just as we're getting started, we'll launch a poll just to see who's in the room. All right, and we've got some people in the chat already. So welcome everybody. Just to get to know you, if you are a covered entity, let us know what type you are, and also friends and family. So we had a little excitement before we started today, not quite as exciting as last time. No technical difficulties today, but we did have some attendees trying to come from Kenya who wanted to know if they were getting paid. So their registrations were canceled. Everybody else who's in here is people who are actual 340B friends and family. So welcome everybody. Always exciting. I'm assuming they must be related to the prince who's always got an inheritance to share with us. So welcome. So it looks like we've got a good mix of people in the room. As usual, lots of FQHCs, hospitals, friends and families. Today, no contract pharmacies or other grantees, but just nice to get to know all of you. And then, as usual, introduce yourself in the chat. I'm Felicity Homestead. I'm the CEO of FQHC 340B Compliance. You all should know me pretty well by this point, but I would love for you to meet Lenika Ellis. Lenika, if you'd like to introduce yourself.
I'm Lenika Ellis. I am the External Audit Manager here at FQHC 340B Compliance.
So I am not sure what's going on, Lenika. I've heard your voice, but you seem to talk without your lips moving. So your camera and your mic may not be synced up. But
okay, let me
unless you're really good at ventriloquism.
No.
It's but all good. So welcome everybody. Lenika is just going to restart her camera and see what's going on. Oh, and maybe it's on my side. That could be it. Apparently, according to Rebecca, everything looks great with Lenika, and it could be me. I am always the one with technical difficulties, so I'm just going to ignore that.
Are we good now?
Yes, everything is good now.
Okay.
Perfect. So welcome everybody. I see we've got people from Pennsylvania. Hey, Jennifer, and Amanda up in Alaska. So welcome everybody. I think we've got another poll as far as getting started for today, just finding out what people are doing for the holiday weekend. Staycation, camping, glamping, which is one of my personal favorite things to do, but I don't get to do that nearly as often. Getting out of town, spending time with the in-laws, which I think is what I am doing. Oh joy, that was my addition to the poll. Lenika, what have you got planned for the upcoming holiday weekend?
Staycation.
Staycation, nice. Awesome. All right, so with that, we'll jump in. So we've got really two sets of things that we're going to talk about today. So we'll start the webinar really focusing on clinic administered drugs. And so we do have these both within the health centers and within the hospital space. And then also at the end, we'll just have 340B program updates. So Lenika, I'll let you take it away from here.
All right. So our agenda for today, we'll start off by talking about policies and procedures, moving on to managing inventory, drug utilization and tracking, oversight and auditing, billing compliance, available resources, and then hot topics in 340B. So when deciding whether your entity is going to dispense 340B clinic administered drugs is HRSA's expectation that covered entities address their processes of procuring and overseeing clinic administered drugs within their policy. So we'll talk about the topics that are listed in the HRSA's DRL related to clinic administered drugs. The first topic is describing the procurement process. Second, how is your CE accounting for 340B inventory, physical inventory or virtual inventory? And the prevention of diversion at the CE. So we have another poll question. When deciding to use 340B drugs in the clinic, does it have to be all 340B or can it be a mixed 340B and non-340B inventory? Did we drop that poll question? Let's see what we're getting.
So it looks like we're getting some varied answers. And the predominant one that we're seeing is no, we can use a mix. And one who says it, or I guess two who say it depends, which is probably my favorite answer on there, because it definitely depends on some states. But in general, the no, we can use a mix is correct.
Yes. So thinking about managing the inventory and selecting a formulary, we do recommend using the formulary, not just going all in, ordering everything 340B, taking some things in consideration, like what care is provided. Each clinic may have a different formulary. Dental formulary may be very different from primary care or school-based clinics versus urgent care. The formulary may vary. Eliminating redundancies and duplicates, identifying cost-effective options for each drug class. Looking and making sure that you don't have the same drug class and multiple drugs when you can eliminate that down to a couple drugs. And then finally, determine whether to order 340B versus non-340B. It does not have to be all or nothing in most cases.
So I'll jump in and just add a little bit to this conversation. So if you're a hospital, you're probably a lot more comfortable with some things being 340B and other things not being 340B, whether you have the GPO prohibition and then you've defined some things as being a non-covered outpatient drug, and so you're carving those out. Or if you are a hospital that's not subject to the GPO prohibition, and then you can either opt to have an item be 340B or purchased on GPO. But within the health center space, a lot of times there can be confusion about there's language for health centers that says you need to purchase at your best price, which is typically the 340B best price. But what we have received as clarification from the Bureau of Primary Health Care is that that requirement should not be in opposition to the 340B program. So if you are not able to track and comply with the 340B program requirements, particularly for drugs that are very low cost, and that there really wouldn't be a difference in price between 340B and non-340B, then you are okay to go ahead and purchase those items on your non-340B inventory, as long as that's not counter to some other state rule. And so typically what we'll see is that items that have J codes for billing, those ones are trackable and reportable, tend to be a higher price differential. And so Lanika's got a sample formulary list, which is quite extensive here. The ones that are highlighted in green, those are a lot of times what we would see on a limited formulary from an FQHC. But things like Tylenols and ibuprofen, where they're very hard to track and we're not billing for them separately, those are items that are fine to not purchase on your 340B account.
Yes, and with that, another poll question. How are you tracking your clinic administered or physician administered drugs? Paper logs, Excel, automatic dispensing cabinets? Let's see what we have here.
And my favorite, heaven help me, we don't track.
Yeah. Lots of paper logs. Some Excel spreadsheets. Well, we have
Good.
paper logs and ADS are pretty close.
Yeah, well done.
Okay, so that's great. Getting to know the room. But me, I came from a health center, and thinking about the cost effective option was big when we decided that we would dispense 340B drugs. The ADS was not an option for us, and paper logs were not working because that's what was previously happening. So we opted to do the Excel spreadsheet via OneDrive. So let's go to the next
And
slide.
I'm curious, I'm putting it in the chat. What types of automated dispensing cabinets are people using? I'm very curious about that. I know in the hospitals, yeah, I see Anya saying Omnicell. We see a lot of Pyxis as well.
Mhm.
And then on the health center side, we're seeing some different, yep, so AccuShelf, Angie is at a health center. And so we see the AccuShelf being a little bit more of a common one in the health center space. So really interesting. And then Molly says using their electronic health record and paper logs. Oh, and Tessa's on the Cardinal IMS system. Awesome.
Yes, that's great. A big mix of systems that are out there and available for us to look into.
Yeah.
So
And
when, go ahead, Felicity.
I was going to say, Rona was saying that they're using the ECW inventory log. That's something that they've come out with a recent enhancement as far as being able to track not just injectable drugs, but now their oral medications as well.
That's great. So when managing inventory, you should think about the inventory type and storage. We talked about physical 340B and non 340B inventory consideration. Are you going to keep those drugs separate? 340B and non 340B. Will you use a labeling system to identify whether those drugs are 340B and non 340B? And then, like we said, inventory log, whether manually tracking or via software, and then lock storage space. Who will have access to your drugs once they're delivered? Is one that you should think about as well. So right on the screen now, you have the sample inventory log that Apexis has available. And this is a great guideline for identifying what data should be tracked when creating a spreadsheet to track your clinic administered drugs. Do you want to use it? Not saying this exact template, but using it as a guideline, adding formulas to automatically track your balance on hand as you put in quantities could be a cost effective way of tracking.
One of the things that we've found is that if you are trying to include all of the medications in your 340B as 340B in your clinic, it gets really overwhelming for the team to have to track all of those items, right? And so if you are strategic about the medications that you do choose to have on your 340B inventory, then the burden for your staff in that required tracking, if it is a manual process, can be a lot less and can be a lot more meaningful for them. And so it's been really helpful for different sites to think about what can you report out of your medical record, and what does your staff actually see as a medication. So lidocaine is one of the items that a lot of times the team is in the health centers don't actually view that as a medication. They see that as part of the procedure. So it can often be very difficult to track lidocaine that's associated with a procedure. So a lot of times we'll see the ceftriaxone doses documented very clearly, where the lidocaine may not be. So just being really thoughtful about what you're asking people to track, and then following up with them on that tracking. And then I see we've got a comment too from Megan about FQHCs where they're talking about the PPS rate, and that they've confirmed with Medicaid that they are not providing payments for LARCs, and that no NDCs are transmitted to Medicaid. Is it still compliant to purchase 340 LARCs as 340B in that situation? So that's a great question. Yes. Even when you're billing under PPS, so PPS is a health center term under the prospective payment system. When you say if you're carving in or if you're carving out for Medicaid, if you are carving in, that includes when you bill items under PPS. And so the when you disclose to OPACE, if you are billing, so the question I always say is, are you billing Medicaid? Yes or no, fee for service? And are you using a 340B drug for those patients? Yes or no? And if you answer yes to both of those, then you say you are carving in, and it is compliant to use that even if it's being billed under that PPS rate. So great question, Megan. Lanique, I'll let you jump back in.
All right, so ordering inventory. Who will order? Will you use the pharmacy? I see a lot with FQs that if they have an in-house pharmacy, they order their drugs through the pharmacy. This sometimes helps when it comes to the tracking, but because you're able to order it through your pharmacy software and it comes in, the quantities are uploaded into the system. I've even seen where they use the clinic, set them up as a patient so that those quantities received are uploaded to the patients and you can report out of your pharmacy software. Or having a clinic buyer, somebody that's just a purchasing specialist. Or are you going to have your clinic managers ordering their own drugs for each clinic? It's lots to consider when you choosing who's going to order. Keeping in mind that separate ordering accounts, being aware of blended accounts. Some wholesalers will link your 340B and your non-340B accounts together, which makes it sometimes hard to identify whether those drugs were ordered 340B or non-340B. So really being aware of what wholesalers you're using, what can be tracked back, and whether it's 340B or non-340B. Confirming 340B pricing with the PVP catalog. The PVP catalog is great to use for different areas. Utilizing the PVP for the purchase history to identify other areas of purchasing 340B drugs. The great thing about the PVP is you can log into there and get the historical purchase report. Sometimes we've seen where this report shows that there are clinic accounts that the clinics made that 340B staff may not be aware of. Nurses have went in and made a mistake and created a new 340B account that you were unaware of. So utilizing the PVP portal for all the different things that it showed for your 340B purchasing.
Yeah. We've got some conversation in the chat where Megan was bringing up that her wholesaler has a med-surg account separate from her Apexis, her accounts. And it was one of those blended accounts where it was essentially saying, what is the best price for this medication? And it may be a GPO price, or it may be that wholesaler's specifically negotiated price, or it could be 340B. And what can be challenging with that is that you don't necessarily know on the invoice what price you're paying. And when you get into the context of a HRSA audit, the initial reports that you receive from the wholesaler don't always provide transparency to that as well. And when you're receiving that medication in your clinic, how do you know which items you're supposed to be tracking if you don't have that transparency? So it's really important to understand with your wholesaler accounts, you know, what are you receiving? We had this issue come up with one of our covered entities that we work with, and it actually came up in the context of a HRSA audit. And in the process of this, it was they were actually not even aware, based on how their med-surg account was described to them by McKesson, in the changes of leadership. They weren't even aware that they had a 340B account because they were told it was a blended account and they were just getting the best price available. But when we were reviewing the invoices to submit to HRSA for preparing for the audit, we saw 340B prices in their account. And then ultimately, we were able to work with this covered entity to be able to work through their process and say, okay, this, these are, what on this is 340B, and the covered entity has actually changed their purchasing processes completely, and is no longer purchasing off of that account. They are buying off of a completely non-340B account because it was never the covered entity's intention to buy those items at a 340B price. So really important to understand. And then in that process too, we also identified that older accounts with this wholesaler were not feeding into the PVP program. So the wholesaler and Apexis are actually working on making sure that that data now flows into the PVP as well, so that you'll be able to see, if you're in the PVP profile, you'll be able to see that information. Because as Lanika said, there is the potential for many wholesaler accounts to be open across the organization. If you're a health center, it could be that somebody at another site opened it. If you're at a hospital, it could be that you're in pharmacy, but somebody in purchasing or central distribution has an account that may have 340B access that you're not aware of. So the 340B Prime Vendor Program through Apexis is a really great place to be able to go and get visibility to all of the places that your 340B purchases are happening, and to be able to do oversight on your clinic administered drugs. So it's nice because it'll show you both your wholesalers and then also your direct orders to allow you to do your tracking back to what have I bought and what are we administering. So if you're not already engaged with the logged in portion of the Apexis website, because I think most people are probably very familiar with going and looking at the FAQs and the Medicaid tool that's on there. But if you're not using this portion of it as a covered entity, there's just a huge opportunity to help you improve the program oversight that you're doing.
And I'll say, when setting up the process at my FQHC, we did have McKesson MedSurg as well, and we're having a hard time identifying which purchases were 340B and non-340B. So me being the person that they hated to see as the 340B coordinator, my theme was, if we track all drugs the same, if we are making sure that we're doing our drug logs for every single drug we have in here, we know that we're good. If we go ahead and just not worry about if it's non-340B or non-340B and track it correctly, we know that we're good in the event of a HRSA audit.
Yeah, you may be doing more tracking, but it's better than missing out.
Yeah.
It's absolutely the best strategy.
So receiving inventory, receiving locations. If it's ordered through the pharmacy, we know it'll be received at the pharmacy. But if we're doing centralized ordering where it'll go to one spot, or will it be delivered to each clinic? Who will be responsible once the order is delivered? Who will be accounting, making sure that the purchase order and the invoice lines up and that everything is accounted for, and reconciling it against the order. And then the inventory log. Once you account that everything is there, who will be the one that's adding these quantities to your drug logs so that they're tracked is a big thing. From my experience, our drugs went to a centralized location. Once the clinics received them, the nurse manager made sure that they matched up, and then they added those quantities onto the drug log, and they were the responsible party for it, making sure that the drug log was stay updated with the quantities received.
So as a pharmacist, I'm a huge proponent of, if you do have pharmacists involved in your health center and your hospital, getting them involved in the process too, whether it's periodically having them come out and do double checks on logs and oversight, or having pharmacy involved in helping facilitate the ordering process. Depending on your state laws, there may be different ways that the orders have to be set up. Sometimes you may be able to facilitate ordering through the pharmacy, or you may have to have individual wholesaler accounts set up for the clinics that the pharmacy can help coordinate the ordering through. So just really important to understand what your state laws are. But if you do have pharmacists, even if they're not the people who are in charge of placing the orders for the clinic, can really be great to involve them in the oversight of that process for the quality portion of it.
As well as pharmacy technicians.
Amen.
So drug utilization tracking, charting documentation practices, administered drugs tracked in discrete fields in the medical record. So making sure you know how those drugs will show up in your EHR. Will it be associated with NDCs, J code? And so I spoke with someone a few days ago, and they said that their EHR would create its own spelling for drugs. So, just being aware of how your EHR reports those drugs out. And then requiring your providers to order all clinic administered drugs in the chart. If you know that order is there, there's one step of the process that we have already covered. It was ordered. And then how it will flow into either your paper logs or your drug logs. What are you going to require your clinic staff to track on your drug logs? Will you have a running balance on hand? Are they going to track your lot numbers and your expiration dates as they go on those logs? Just taking all those things in consideration. And then expired and waste drug inventory. That's one thing that HRSA points out, that you have to have a process for expired and waste. Who will be the one that's checking and how often? As working in a pharmacy, it's second nature for us to look at expiration dates and have a process for checking expiration dates. In the clinic, I found that was not didn't come as secondhand as it did to us in the pharmacy. So that was one thing I had to implement, was when we will check for those expired drugs. And then the reverse distributor process. So if you have a reverse distributor, I know with mine, we still had to identify which drugs were 340B and non-340B, so that they are credited back to the correct wholesaler. So it's very important that you put those processes in place when possible to know which are non-340B and 340B. And then documenting patient-specific waste. You use half the vial of medicine and you discard the rest, making sure that your clinic staff are aware that we need to know where the other half went, in a way of tracking that as well.
And just a couple pointers on the charting and documentation that I often see is that systems that are hard-coded for medication ordering tend to work a lot better just by the nature of how the systems are built. When you have the opportunity to free text in the name of a medication or free texting in the dosing of a medication, that is an opportunity for errors to happen, both in how the orders are written, but also in your billing process. So that's going to lead nicely into what Monique is going to talk about next.
So oversight and auditing. Oversight for 340B drugs starts at the beginning. Cycle counts. One thing I feel that was important with our process was spot checking drugs during the month. If you're spot checking a drug as you go, it's easier for you to figure out where the two that disappeared in the last 2 weeks went, versus waiting for the end of the month to count, or having a quarterly count. If you're spot checking those drugs as you go, it's going to be easier for you to track if you're missing something. Inventory reconciliation. What has been purchased compared to what has been dispensed or administered. Making sure that all those line up. And then audits. Auditing not only for your quantities that's there, but also for diversion and duplicate discounts. And then training. For me, 340B training starts at orientation. If you teach people the why we have to track and why with 340B, usually they'll go ahead into the clinics and do it the way that you train them. I found that it was harder for me to get the staff that had been there for years on board with tracking 340B versus the new nurses that came in. It was easier for me to get them on track to tracking it because they knew the why and they understood why we had to track those drugs a certain way. So here we have sample audit templates. The one of those are the Apexis PVP template. The other one is just an idea of how you can keep up with the reconciliation of your audit logs. Having sampling 10 drugs a month where you look at the starting count, the quantity received, and then looking at your utilization and calculating the end count to make sure that it actually fits. And then documenting those variances. HRSA knows that we'll have mistakes, but we have to show intent that we are providing oversight of these 340B drugs.
And so one of the things that's important in conducting these audits is, making sure that they're happening on a regular basis so that you can provide feedback to staff. A lot of times we can see that as things get busy within the clinics or the hospitals, it can be tempting to push these off and maybe not do them necessarily on the schedule that your policies and procedures suggest that you will be doing them. But the longer that you go between conducting these, the more opportunity that you have for bad habits to get ingrained and for people to not necessarily be conducting the oversight of the inventory the way that they should be. So, making sure that you, as Lanika said, get training done early and that you're checking in with your teams often, that things are being handled correctly is really important. The other pieces, as we'll talk about too, is just making sure your billing practices are correct. And so, Lanika, if you want to talk a little bit more about that.
Yeah, so another tool that we have on the PVP Apexis website is in the Resource Center. If you click the drop down, Medicaid is one of the drop downs. You're able to click Medicaid and it will take you to this page that's shown here. And then you're able to choose your state. Once you choose your state, they'll have an area where it says it says clinic administered fee for service or something right there where you can click and it'll have documents attached to your state specific billing requirements. So Felicity, you want to go more into?
Yeah, so it's really important to make sure that you understand your state billing requirements. And then it's also important, especially if you are on a bordering state, that you are aware of all of the states that you are billing, or if you are on a vacation state, Florida being a great example of that, right? You want to make sure that you understand all of the different states that you could potentially bill Medicaid fee for service for, and that's really the key. Right now, come in the future, we're going to be thinking about Medicare as well and complying with our Medicare billing requirements coming up in 2024, and we'll be talking about that in a future webinar. But just thinking about what state are you billing in, as far as the state you're in and other states you could be billing, make sure you understand the billing requirements because they are very different. Some use the Medicaid exclusion file, which is when you're listing as carving in or carving out on OPACE. And Lisa Schultz says vacation state. That's where she lives. And so you would be listing your NPI or your Medicaid billing numbers there. Other states have their own separate processes where you may need to enroll directly with the state in addition to your designations on OPACE. And then you may be sending them data on a quarterly basis. They may want you to use modifiers. So there's a lot of different ways that the states handle Medicaid billing requirements. I mean, you want to make sure that you're not only complying with the federal requirements from the Office of Pharmacy Affairs designating appropriately on the database, but you're also complying with the state. And then as you start auditing that, It's important to look at your billing forms that you are actually submitting for your clinic administered drugs. So if you're the hospital, that may be coming out on a UB04 or a CMS 1500 HCFA form. If you're a clinic, it's going to be on the CMS 1500 HCFA form. So you're looking for items that are line item billing, typically coming across with a J code. And then specifically, you want to make sure that the billing numbers that you are listing on OPACE align with the billing numbers that are on your forms that you are submitting when you bill to a Medicaid fee-for-service. So we see a lot of confusion with that. Sometimes we see that the provider, who is the actual clinician's numbers, are listed on OPACE. You've got a lot of those. That's a huge lift, and it's not required, so don't do that. Sometimes we see the site NPIs listed, but that may not actually be what you're billing under. So if you have a single organization NPI that you bill under, that would be what you would list on OPACE. If you bill site specific by the NPIs, you're going to list those numbers on OPACE. So just be really careful about what you're billing, and then make sure that when you're testing your how you're billing and your compliance of your billing, you're not just looking at your medical record to see what does it show in the medical record, because that's not always the final claim. You want to get with your billing department and ask them for the final version of the claim that was adjudicated, because a lot of times you may have either part of your system or a partner that you work with in the billing process may be doing additional work to the claim. And so sometimes we've seen that modifiers are present in your medical record but stripped off before the final submission, or vice versa, where the modifier wasn't present but it was added in the final submission process. So make sure that you're getting that finalized claim to do your reviews. And in that too, make sure you're looking at your what did I administer and did I bill it correctly, because there's a lot of missed opportunity that we see there. As far as 340B goes, you're not going to get in trouble for not billing enough when you should have, but it is a missed opportunity for your health centers.
And remember, it's not set it and forget about it. You do have to go in there and check and make sure that it's a continual process.
Yes. Yeah, it's really important. Build a good relationship with your billing and finance department, so that they know that if they make any changes to those billing numbers, any new additions, any changes in their processes, any new states that are being added, that they know that to communicate that with you. So it's helpful for you when you're doing your checks that you can test for that, but also if they're feeding that information to you, just really important. So always good to check at recertification and a couple other times during the year.
So the next slide is just a resource slides for some of the things that we addressed previously. This top one is 340B University, or 340B PVP, does have a small course on managing physical inventory that I encourage everyone to go and take a look at. So we have, of course, Apexis we keep, there's a few. And then the NAC manual as well addressed clinic administered drugs.
And we attempted to link to the NAC manual, but the link is not live currently. I know NAC is working on a updated version. The last one was published 5 years ago, so there are some pieces of it that are a little bit out of date. If you don't have access to the previous version and you do need it, please feel free to let us know in the chat. We could get that to you directly. Just where it's so outdated, we didn't want to upload it in the handouts, but if people would like to see that, we're happy to share that. All right, and so just looking at things that are changing, what's happening. As always, the 340B program does not stay the same. Always just new developments. And so some of the changes that have happened since the last time we talked, and I made a list for myself because we've had a few more even than what's on the slide. We've had a total of 5 changes this month. We had 3 manufacturers who tightened their restrictions and 2 brand new ones that have come in. So as far as tightening restrictions, Novo Nordisk, Exelixis, and Bosch all tightened their restrictions. Bosch was the only one who imposed those restrictions on the grantees, but essentially all 3 of those went down to the single designation model. And then the 2 new manufacturers to impose restrictions on hospitals are Organon and Teva. And so the details are there. All of the manufacturer restriction letters are in the handouts if you want to take a look at those. And if they haven't been uploaded yet for your access, they will be added in just a second. And then just to talk a little bit more, we're seeing so much movement on Capitol Hill. So the last time we met, we talked about different bills that were being introduced. And so we talked about the Bouchon bill and then a couple other bills that were rolled in together into that Patient Act. Where they were looking at creating 340B reporting requirements and transparency requirements. And so I'm actually going to skip ahead for 1 second. So this one came up first. This one is from the House, and I would put this in the more oppositional to 340B. And it is it's a request for information that came out from the House side of Congress. And what they are asking for was an overall request on drug shortages. But really interesting is in that request, they specifically call out 340B a couple times. So in the preamble to their questions, they have a statement that says, scholars and stakeholders have also pointed to the existing federal pricing containment programs and mandates such as the 340B drug discount program and Medicaid drug rebate programs as drug shortage drivers. And so then they go on in their questions to say, what, if any, has the growth in the 340B program played in the role of drug shortages? So overall, they've got 14 questions about drug shortages, but specifically calling out 340B. They do also have questions about the inflationary penalties for Medicaid and the ones coming with Medicare. But it's very interesting that they have targeted the 340B program. This was a strategy that they took about a decade ago, saying that 340B program drives drug shortages. At that point, it was disproven. As a driver, and Lisa's adding some comments when Cassidy was in charge in that era. Yes, this was definitely Cassidy piece. He was on a webinar yesterday, which was very interesting, and he was talking a little bit with some information more. He's more focused on PBMs right now, which is good, but just as far as this goes, it's interesting because the 340B program is, as much of what we interact with it, is at the contract pharmacy level, right, where it's retrospective. So the patients are receiving a neutral inventory and then it's being replenished. So you wouldn't necessarily say that the 340B program there would impact purchasing or shortages, because the initial inventory that is dispensed is the pharmacy's inventory, and it's a normal patient pattern. So the question would be, is it on the initial purchases by the hospitals or the grantees for their prospective purchases? And so in the original conversations that they had about this, the examples that they used previously, and Lisa's brought it up, is talking about stockpiling penny pricing. But in the previous situation, what was found was that most of the drugs that were on shortage were actually inpatient drugs, and we know this is not an inpatient program, this is an outpatient drug program. So they were able to very effectively dispel this. And if you look at the 340B program as a percentage of the overall drug industry, we know it's a very small portion. And so there were some interesting statistics that came out recently, which showed that the rebates that, yes, the slide deck should also be in the handouts, Meredith. If it's not already there, it will be there shortly. The statistic was that the rebates and the savings of the 340B program itself is only about half of what the manufacturers actually give in their commercial and PBM rebates that they give by choice to other payers. So it would be very hard to argue that this mandated program, which is only half of what they actually give as discounts by choice to other areas of the market, would be the driver of shortage. So just interesting conversation. But this is drug shortages is a major issue, but there is this questioning of the 340B program within this, and so interesting is Rona's response, but just something for us to keep an eye on, right? Because any opportunity for an attack on the 340B program is essentially what we are seeing. So really important that we do not stockpile any drugs that are on shortage, right? Use appropriately. Everybody needs access to these medications. We will see that the different advocacy groups and the different stakeholder groups will be providing templates and letters to help their members respond to these. So anticipate that you will see from your different associations the opportunity to respond to their supported letters. And then if you feel so inclined to also respond yourself, really great to do that. I see Lisa's chiming in about the importance of having a voice. And Lisa, when we get to the end, if you want to have anything to say as we wrapping up about writing these letters, I'll bring you up on stage, Lisa. And then, so the other one, which is another request for information, but it's coming from the Senate side. This actually is positive. So every time we get something like this, it feels scary, but this comes from the Gang of Six, who are actually more pro 340B covered entity and supporting of the program. And so the questions that they asked are interesting, they're thoughtful, they're thought-provoking, and so they are what I would say intended to have generate conversation from the stakeholders and advance the program forward in a meaningful way. And that this one will also be in the handouts. And so as far as questions they ask, right, they want to make sure HRSA has adequate resources to oversee the program. How do we as stakeholders see that might happen? Policies to ensure consistency and certainty of access to contract pharmacy arrangements for covered entities. So that in and of itself, you can see that the people who are drafting these questions are would be more in the proponents of the covered entity camp. That is a very pro covered entity question to be phrased. And then also talking about, there are questions about making sure that the benefit of the program serves the covered entities and their patients, not others, making sure that we have opportunities to ensure the prevention of duplicate discount. And then there is language there too, which is important, about oversight, common sense, targeted integrity measures for the oversight of the program, and then transparency on the use of savings. So these questions, one of the thoughts around it is that, oh, Lisa's dropping. So She will not be joining in the conversation, but she will see us next month. But one of the thoughts around this is that the Gang of Six actually released it in response to some of the proposed legislation that we saw as a way to perhaps pause those other pieces of legislation from moving forward too quickly before we've had a real bipartisan approach that was going to create meaningful 340B program change. So just really interesting developments as far as this request for information coming out. So that would be considered very positive. And then we've got time for discussion. And then just as we transition into that, just wanted to let you know we are working very hard to plan ahead. And so in July, we're going to be talking about adding and expanding entity-owned pharmacies. So it's the new term that we're using instead of in-house pharmacy, because not all pharmacies are inside the four walls of your building. So entity-owned pharmacy is the new term that we're moving towards. In August, we're going to have Cardinal Health joining us. It has not been determined which ladies from Cardinal Health yet, but some of the ladies from Cardinal Health are going to be joining us to talk about getting ready for the DSCSA changes. And then in September, Jennifer Cincanetti, who is on the call with us, is going to be talking to us about using order sets in primary care and in ambulatory care to really enhance practice. So it's something that we use very frequently. We're using very frequently for hospitals, but in the clinic setting, we don't tend to use order sets. And so we are, we're looking forward to learning more about that. And Caitlin says that it looks like she's going to be joining us as our presenter. So thank you, Caitlin. I'm going to be getting that updated in our list. So we're super excited to have you. And so as far as conversation, Megan, I saw you had lots to say about your clinic or your site, I'll say, and inventory. If you are interested in joining us up here and sharing your experience, say so in the chat and we can bring you up on stage. Or if anybody has questions, anything else you'd like to talk about, let us know. And then Sue, Amanda says, for July, will specialties be part of the conversation? So I would assume, yes. So Kristen is amazing. Her background is that she actually started in a specialty pharmacy. And so she has worked with like a rheumatology group in developing their pharmacy services. She has done a lot of work no worries, Megan. She has done a lot of work with different specialty services for pharmacy, but also regular pharmacies. And so she has experience going through URAC accreditation. More recently, she has been working with with fertility treatments too, and looking at pharmacy services focusing on assisting with infertility. So she has been involved in opening up pharmacies as well as acquiring pharmacies and converting them from an independent pharmacy to an entity-owned pharmacy. So she's got an amazing wealth of experience to be able to share with us. So I'm really excited about that. Lanika, other pieces, any other words of wisdom you'd like to share as far as clinic administered drugs? I'm going to take a peek. Sue's got a comment here.
Yeah, they're not as scary as we make them out to be. Just holding the people in your organization accountable, I think, is the biggest part where I see entities have problem with. But just making sure that the staff understands the importance and that they'll be held accountable for tracking the drugs. And clinic administered drugs was a really, really, really hot topic before the drug restrictions. Like that was the wave that we were on for a long time. And we kind of seen it slow down, and now that HRSA is back to doing on-site audits, um, in my experience with on-site audits, they may ask to count your clinic administered drugs, ask about your inventory, ask to see what your balance on hand is, different situations like that. So just making sure that you apply all the tools that we gave you today to your drugs.
And so I'm looking, I've got a question from Sue. It says, since Joint Commission requires clinic administered drugs to be logged and tracked, has anyone had much luck with getting your organization to downsize your 340B clinic your 340B clinic inventory? I'm hearing since JC requires it, we need to be compliant anyway, but they're not. So that's it. That's an interesting question. It really, my experience has been it depends on the site. It depends on the experience. Typically, when you're coming out of a HRSA audit, there's a lot of opportunity for getting buy-in at that point, but that's really a hard time to be gaining that buy-in. And then, as far as it goes, you may still be doing the tracking of those items to comply with your other regulatory boards, but the purchasing, a lot of times what we've been able to do is say, using the financial assessment and say, by switching these over, this is the impact that we're seeing, and it's a very small dollar impact. But then when we look at the additional manpower tracking that we're going to have to do to ensure that we are having the 340B compliance that we need to for 340B, not for Joint Commission, that's where the savings balance is out. And so we would encourage this, or this would be considered to be a best practice. That type of language can be helpful. Your thoughts, Lanika?
No, same. I think that, like you said, around the HRSA audit is the buy-in where it's just like, oh goodness, what have we been doing with our clinic administered drugs? And but just following up on your same advice.
Yeah. And then Sarah's asking about education for other departments besides pharmacy that we'd be willing to share. And so I guess, Sarah, are you thinking, and you can just put it in the chat, are you thinking about maybe more like detailed, like step-by-step pieces? Or just kind of understand, or just kind of an overview of the 340B program for staff and the importance of tracking?
Yeah, she's saying that she's having trouble with educating in the places that she's not used to working. Same with me. I visited each clinic and did the education. What I found helpful was to talk to maybe like the nurse manager or somebody that's very, very familiar with the happenings in that department or clinic, and then tying it back into 340B.
Yeah. And what I would say is that we don't have that yet, but we will take that down as something we can develop and potentially share. We are always working on different tools that will be helpful for others. And so that'll be something that we can take back and see. The other place that is always a great resource to look at is Apexis. And I know that they have all sorts of different trainings there. The 340B University on Demand can be really helpful. Sometimes what we suggest is using just very specific modules, not necessarily requiring everybody to go through the entire training, but there may be one module that you ask people to participate in. And then the last question that we've got is just a poll to see who's going to be at the coalition, and who will, if you're going to be there. And then If we can put it in the chat, if we do have our booth number, we will be there. I don't know our booth number off the top of my head, but if somebody on our team has our booth number and can put it in there, that would be fantastic. If not, we'll be posting it on LinkedIn. Looks like most people are not going to be there. I do know that we're going to try to do a little bit of a meetup at the conference. Lisa's not here, so she's usually the one that has the details about that. So if you're on the Facebook group, we will post it there, and look forward to seeing you. If you are in the exhibit hall, stop by and see us and say hi. And if you see us out and about, also say hi as well. Linique and I love to make new friends, and we just really appreciate you all being here. Feel free to add additional topics that you'd love to see in future presentations. The ones that we've got coming up are definitely based on items that you all have asked for. So really appreciate you ladies joining us for lunch today. Thanks, everybody.
Bye.